Hello, good morning. I'm Ashok Kurokade, consultant rhinologist and anterior skull-based surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of our organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Anterior Skull-based Surgery Webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull-based surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull-based surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
I'd now like to introduce our 4th speaker for this morning, which is Professor Alkis Psaltis, who is the current Head of Department of Otolaryngology, Head and Neck Surgery at the Queen Elizabeth Hospital in Adelaide, Australia, and he's Professor at the University of Adelaide as well. He has vast experience and completed actually 3 surgical fellowships following on from his training. These were based in Auckland, New Zealand, Charleston, USA, and at Stanford University. He has a PhD and his research was based on biofilms and chronic rhinosinusitis, and he has written over 150 peer-reviewed articles as well as 16 book chapters. He has delivered over 120 talks at both international and national levels, and we're delighted today to be hearing one of these talks. And today he's going to be talking on maxillary sinus and the surgical options.
Thank you, Louise, and thank you, Ashok and the organisers for inviting me. And it's always It's always a privilege to follow Sal because he always delivers such crisp, clear lectures, and hopefully this will flow on from what he's already demonstrated today. So I'll just share my screen. Actually, it's disabled screen sharing, so can someone just allow me to share my screen? Okay, great, thank you. Great, so I'm going to be focused on the maxillary sinus, which often as registrars is what's left to us to do when the fellow or the consultants are out of the room. And it's a sinus that's often deemed the easiest sinus to tackle, but if it's done poorly, it really can lead to significant morbidity for the patient. In this talk, I really want to not just focus on the surgery, but on the philosophy behind why we need to think about why we're doing the surgery. And this latter would really apply to all the sinuses. We're not simply technicians who perform the same operation every time we do a sinus operation. We need to think about the disease process and what we can do to tailor our specific surgery to that patient. So in summary, over the next 30 minutes or so, I'm going to speak to you about the inflammatory disease load, how we can classify disease according to severity, and what's a ladder that we can use when we're thinking about how to perform surgery on our patients. So obviously we owe a lot to this gentleman and then to the individuals that really populated his ideas throughout the environment. And this is Messenklinger, who was really the first individual to go beyond simply punching holes in the sinuses and to think about how the sinuses drain. And with this concept, the fundamental drainage of the anterior sinuses was the osteomeatal unit. And so when he came along, he started thinking about the fact that we should be addressing these functional units rather than just simply putting a hole anywhere along the sinus wall. And as a result, the outcomes were better. And this is the osteomeatal unit sitting between the bulla ethmoidalis, sitting between the uncinate process, and we can see the semilunar hiatus here. And that really is an important unit, as we said, for the drainage of the sinuses. So back in the days prior to Messenklinger, we used to do inferior meatal antrostomy, simply punching the medial maxillary wall and wondering why our patients still had postnasal drip, ongoing maxillary sinus pressure, despite having a patent sinus. And we also see it when we see patients who have surgery performed where the natural os isn't connected to the accessory os. And here we can see that with a 0-degree scope, we can see that the uncinate hasn't been taken down and there's the accessory os. And so if we get confused and we don't address the natural os, we'll obviously be leading to the possibility of mucus recirculation. And this is a video that I've borrowed from Richard Douglas, which really shows beautifully mucus recirculation. And you can see here that the natural os hasn't been addressed. And you're seeing the cilia beating away from that hole that's in the posterior fontanelle towards the natural os. So despite there being an opening there, the cilia, which have been pre-programmed, are ignoring that surgically created hole in terms of drainage. So if we look at these three patients, they've all got different disease burdens, and probably different etiologies. The first individual had some very minor maxillary sinus opacification. The second one, more circumferential. And the last one, we can see double density showing fungal deposition. Should we be doing the same surgery on these three patients? Well, we also know that the types of disease are different. And here we can see patients who all have a poor prognosis following sinus surgery. This is a patient with pus, and we generally show that if there's pus present and you culture Staphylococcus aureus at the time of surgery, you have a 75% chance of getting a post-operative infection with the same species in the first 6 months after surgery. Here we've got a patient that I operated on in South Carolina with allergic fungal sinusitis. And here you can see the thick, tenacious fungus, which we're pulling out of the nose, almost like a fishing tackle. It's rubber band-like. And this poor individual had this thick rubber band of fungus sitting within their sinus. And then we have the patients who have got eosinophilic mucin. And we can see that very similarly to the fungus, it's very hard to get out. And unless we do more extensive procedures in these last two patients, we're probably not going to remove the inflammatory burden, and these patients are going to get recurrent disease within 6 months. So essentially what we're talking about here is the inflammatory load. So whether it be biofilms, whether it be staphylococci enterotoxins, eosinophilic mucin, fungal, or polyps or osteitis, what they have in common is that they have a very high inflammatory load, and in the majority of cases, a high eosinophilic predisposition. And it's this inflammatory load which can perpetuate disease. Now, inflammatory loads peripherally and also systemically have been well studied. Patients who have high eosinophil counts in their blood and high eosinophil counts in the tissue have been shown consistently in multiple patients to have worse CT scan disease, so higher Lund-Mackay scores. They've also been shown to have greater disease endoscopically when you look inside their nose. If we look at the same two parameters, eosinophilic blood and eosinophilic tissue, these patients also have worse post-operative outcomes. So why is the eosinophil so important? Well, the eosinophil is really what drives the inflammation in a large number of these patients. The eosinophil is a multifactorial cell. It's got multi-functions. It can act as an antigen presenter. It can elaborate cytokines, pro-inflammatory, and it has the ability of attracting more and more eosinophils, so perpetuating the inflammation. And eventually, it releases products that lead to tissue injury, tissue breakdown, and eventually irreversible tissue remodeling. And as I said before, the most frightening thing about the eosinophil is that it can persist and allow autocrine persistence. So if there's a high enough number of eosinophils, the inflammation will perpetuate. So should we be doing the same surgery for patients with different extent of disease? The patient with minimal disease and the patients with complete opacification? Well, the answer is no, and you need a structured lab. What I advocate is that for patients with osteomeatal unit disease largely, you can simply do a swing door uncinectomy, as Sal spoke about in his previous lecture. And it's really important to get the residents to do this correctly and to remove as much of that uncinate as possible. And as Sal said, you really want to identify the natural os, not simply put a suction into where you think it is and tear away the mucosa. You want to remove the vertical and the horizontal portion and try to leave as much mucosa apposition as possible. That will ensure a really good post-operative result and a stable sinus where you don't get crusting and post-operative inflammation subsequently. And for these patients with that minimal osteomeatal unit disease, they will do extremely well with simply removal of the uncinate bone, not enlarging the os much more than that. What about the patients who have more circumferential disease? So these are the patients where you get into the sinus and you actually see some significant pathology. So again, the process starts the same way. We remove the uncinate process. We open up the natural os with a 30-degree scope. And what we start to see is that this individual has polypoid changes to all walls of the sinus. And it's really important in these patients that we extend the antrostomy posteriorly. We remove the posterior fontanelle right up to that posterior maxillary sinus wall. And this is important for a few reasons. First of all, it allows us to visualize the entire sinus once we put a 30-degree scope in. But it also allows us to use angled instruments where we can place them posteriorly, tilt them anteriorly, and remove that disease in the dependent and anterior-most aspects of the sinus. So you can see that had you not extended this antrostomy further, you probably would have missed that disease hiding inferiorly and then wondered why the patient had recurrence of the disease in the early post-operative period. It then takes us on to patients with grade 3 disease or complete opacification. Now, these individuals are patients either with high inflammatory loads, so the fungal patients, the biofilm patients, or the patients with that thick eosinophilic mucin, or patients with poor mucociliary clearance, the patients that can't get rid of the fungus or the debris once it develops. And these are our cystic fibrosis patients, or our patients who've had disease for such a prolonged period of time that they have mucociliary crippling, they have fibrosis, and they have a non-functioning sinus. And in these patients, they'll end up developing a high inflammatory load purely because they can't clear the sinus disease. So there has been a study that looked at how much of the sinus you can access with a 30-degree scope, angled instruments, and a 70-degree scope. And this study by Roby et al. Looked at sort of what you could visualize and what you could access with a 30-degree scope. And what they found was that with a 30-degree scope, you could probably access between 40 to 50% of the sinus. With a 70-degree scope, you can access probably 60 to 80% of the sinus, but without extending that antrostomy inferiorly and anteriorly, you're missing about 20 to 30% of the sinus. So the dependent portions of the disease where it's very difficult to get access to and remove. So in these patients, why is it important that we need to do a more extensive procedure? Why is it so important to try to get out as much of that inflammatory disease as possible? Well, the answer comes back to the T cells and the eosinophils. So when we leave residual disease, we're leaving primed T cells and we're leaving eosinophils behind. And as I said before, these cells can create autocrine persistence, attract more eosinophils, and therefore perpetuate and build on the disease again. So you can remove 60% of the disease, but if you leave 40% of behind, it's only a matter of time that the disease will repopulate. And that's the reason why for these patients, we really want to be operating and removing as much of the fungal disease as possible. So we can do this either via a canine phosphatropine, or we can do it via an extended approach. Now, a canine phosphatropine is something that, that PJ populated probably 10 to 15 years ago. He still does it when he operates, but it's probably fallen out of favor a little because the kits are no longer commercially available. So if you've got a kit, it's fantastic, but if you don't, they're no longer in production. But in essence, this canine phosphatropine uses anatomical landmarks to create an anterior window, access the maxillary sinus, and remove the disease. And when first described, simply two anatomical landmarks were used, the mid-pupillary line and the floor of the nose. And where they intersected was where you made your entry window. And here you can see an axial view of a cadaver, and you can see that we can access all aspects of the sinus through that portal or that anterior window. It's simple to do. You can put some local anesthetic. You don't even need to do that. In the gingivobuccal sulcus, you make a small incision, and then you use a freer to elevate the mucosa off the bone. You identify your landmarks that we just spoke about, and you puncture a trophine in using a drill. And you probably don't even need that trophine set. You can do it without the trophine set. You can even do it with an osteotome. Here you can see that in this particular case, they're using the trophine set. They're using plenty of irrigation not to burn the bone. They've made their window. Now we're looking in the nose with a 30-degree scope, and you can see the removal of the polyps using the microdebrida, the straight microdebrida. And you can see how it can sweep across the surface, removing all of the disease that's present. And it's really important to remove all the disease, but not to strip the sinus, because we all know that once you strip the sinus, you leave its bone exposed, which can result in osteitis, and eventually, obviously, in persistent crusting and inflammation. So this was a really good, quick, effective 10-minute procedure to remove as much of the disease as possible. And these patients generally did pretty well. And this is a patient post-operatively, 6 months down the track, and you can see there's none of that inflammation that was seen on that video. This was assessed by PJ's fellows who looked at the results. And what they found that was with this trophine process, patients with complete opacification of the sinuses were disease-free in the large majority of patients between 2 and 3 years. It was also very good in patients with Samter's triad. So this is a paper that looked at purely patients with aspirin-exacerbated respiratory disease. And here you can see very similar levels of control with the canine phosphatropine. With the canine phosphatropine, there was only 4% recurrence. With a modified medial maxillectomy, a standard maxillary antrostomy, there was 14% recurrence. So simply just enlarging it without taking it inferiorly. But there are problems with the initial technique that were described. And when you looked at the complication rate, there was an extraordinarily high complication rate, albeit soft tissue injury was the most common complication. Pain, facial tingling was also present. And in some individuals, there was numbness over the cheek. And the reason for that numbness is evident in the picture. You can see that there's a nerve transgressing the front face of the maxilla. And if you injure that nerve, you'll cause damage to the sensation that it supplies. The good news is that of the 76% of complications, 3/4 of them resolved by 1 month, but it still left a significant proportion of individuals with some paresthesia or some facial swelling. The rate at 6 months was much less, so only 1 in 10 patients had persistent symptoms. But if you tell your patients that I can remove all of your disease, but 1 in 10 of you are going to have persisting soft tissue or facial numbness, I think the majority of them would run away from that. And so why did these patients, or why did these early studies report such a high rate of complications? And the reason for this is in the way that the infraorbital nerve ramifies or branches when it comes outside of the maxilla. Here you can see the very favorable ramification. We can see the main trunk coming out, remaining as a single trunk, and then branching once it's reached the bone. So here, the nerve is protected by the anatomical landmarks. Unfortunately, there are alternate ways that the nerves can branch. You don't necessarily need to have a main nerve coming out. You can have a main nerve with multiple branches as it comes out, or you can simply have multiple branches that don't even come out of the main nerve. And so in the second and third patient, you can see that if you use your anatomical landmarks of the mid-pupillary line and the nasal floor, you're going to guarantee a small nerve injury with some element of neopraxia. And depending on the distribution of that nerve to the skin, depends on the extent of numbness the patient will experience. So in order to address this, the authors of that initial paper then decided to look at a new modification where you just didn't simply use the landmarks, but you used an endoscope. And here you can see that if we were to make the incision or the window through where the anatomical landmarks would tell us to, you'd be running right through the nerve. So in this particular case, the surgeons modified the approach. They saw the nerve as represented by the arrow, and they lowered the antrostomy or the antral window to a place where the nerve wasn't involved, and therefore reducing the risk of complication. It's really careful though that you don't go too low, enter the nerve roots of the teeth, and then lead to a loss of dentition. So the results of this second study show that the complication rate dropped from 75% down to 45%, and there was a much less persistence at 6 months of 3% rather than 10%. Now, the reason we think that the individuals got so much of these soft tissue complications early on was initially when the study was performed and the technique was described, we used to lift up a lot of the mucosa off the front face. And so by lifting a lot of the mucosa off the front face with the FRIA, you're actually creating a dead space for soft tissue swelling. If you limit the amount of bone that you expose, the soft tissue complication rate also reduces absolutely dramatically. So this then gives us the alternative. So if we're not going to do a canine phosphatropine, what can we do instead that's equally as effective? And this is the extended maxillary approach, which really isn't that difficult to do. And for anyone doing maxillary sinus surgery, I would suggest that you become familiar with this technique early, because it's really nice and easy to do, and it's quite effective when you do it. So with an extended maxillary antrostomy approach, it always begins with doing the antrostomy. But in this particular case, we remove the medial wall of the maxilla, or at least 2/3 of it. So we've got an L-shaped axis to the sinus. This is a cadaveric picture of what it looks like. Here you can see that we've done the antrostomy. This is looking anteriorly on the right of screen and posteriorly on the left. You can see that we've removed it right down to the floor. You can see the stump of the inferior turbinate posteriorly. You can also see the blood vessels of that inferior turbinate and the need to not go too far posteriorly and to always cauterize the posterior stump of the inferior turbinate when you perform this procedure. What else you can appreciate is that the anterior third of the inferior turbinate has also been left behind. And it's important to do this so that you don't get drying out, crusting, or contracture of the lateral nasal wall. With this approach, if you want to get access to that antero-inferior aspect, you can extend it below Hasner's valve so you don't risk injury to the lacrimal sac. And here you can see that by extending it right up to the piriform aperture below the inferior turbinate, you can actually see the middle, the front wall of the maxilla, and you can also see into the floor. So you've got exceptionally good access to the entire sinus with this technique. So this is a procedure which we're doing in this particular patient for really significant maxillary sinus disease. So this patient's had previous surgery before, and you can see that there's quite a bit of scarring. And an antrostomy was performed. Here we're clamping the head of the inferior turbinate, and we're doing that for hemostasis. We then cut along the clamp line, trying to preserve as much of that head as possible. We can then remove the posterior or the middle third of the turbinate. And this is where we try to get access now to our medial maxillary wall. And I like to use flaps, which are inferiorly based, because by using the flap, you can cover any of the bone that you're exposing so that you don't get crusting. Here we then make an osteotomy. You can even do it with a freer because often the bone is very thin here. And that's in line with the antrostomy. You don't go more anteriorly, otherwise you'll create an injury to the lacrimal sac. So you basically make your vertical osteotomy in line with the natural os. And here you can see we can now remove this thick, tenacious, eosinophilic, loaded mucus. And you can almost see those eosinophils there. Now, in this particular case, we can then extend it. And here you use an adult backbiter rather than a pediatric because it's a lot stronger, so an ostrom punch. And we are coming below the axilla of the inferior turbinate to avoid injuring the lacrimal system. And you can see that that anterior extent was really critical so that we could get that anterior inferior disease. So even though we got quite a bit out with the approach by simply extending it inferiorly, we couldn't access that anterior wall particularly well. Now this is with a 30-degree scope, and you can see at the tip of the screen that you can actually see that anterior wall nicely. This is a critical step. You have to cauterize the posterior third of the inferior turbinate, otherwise you run into bleeding. Now, I often get asked at this particular time in my talk as to why don't you just chisel that posterior wall off? I don't do any chiseling with this procedure. And the reason I don't is that you don't want to damage the descending palatine nerves. And so if you simply remove that part of the medial wall that's thin, that is allowed to be removed with a Blakesley or with a Tilly-Henkels, you won't risk creating damage to that posterior descending palatine nerve. So you won't get numbness of the palate, which you could inevitably get if your osteotome went a little bit too far back. And so this is a patient 3 months down the track. You can see that they've got a nicely mucosalized sinus and no ongoing disease. And you can see the importance of preserving the head so they don't get that anterior crusting. For those of you who do proper medial maxillectomies for inverting papillomas, you'll all notice that when you remove that head of the inferior turbinate, these patients crust for months, if not years, down the track. So you're trying to preserve that for humidification. The results of the endoscopic megarantrostomy or modified medial maxillectomy have also been well described. This was from one of my mentors, Peter Wong at Stanford. They showed very similar rates to that seen in PJ's study with his canine fossa, that all patients had an improvement and the vast majority had complete resolution of their symptoms. A similar study done by another one of my fellowship directors, Rodney Schlosser, also found very similar results. All patients improved. 80% had complete resolution of their disease and symptoms at 35 months. Now that study by Peter Wong, when I was there at Stanford, we then did an 8-year follow-on study of those initial patients. And what we found was of that initial cohort of patients, the success rates were sustained over an 8-year period. So the initial 11-month success rates were mirrored at 7 years. And these are just graphical representations of how their symptoms and their lung Kennedy scores improved. So we've taken this to the cadaver to look at how the extent of maxillary sinus surgery affects not only distribution of saline irrigations, but ability to clear disease. And so in this particular study that we published last year, we used cadavers and we basically videotaped the irrigation going in with different extents of disease. And we also used cat food, wet cat food, to represent disease and how much we could clear with the different extents of surgery. And what we found was that as we performed more and more surgery, the ability for us to visualize the entire sinus improved. So we can see that on the left of the graph, we've got a standard antrostomy. On the right of the graph, we've got an extended modified antrostomy where we've extended it anteriorly and inferiorly. And the amount of the sinus that we can visualize increased dramatically with all 0, 30, and 70-degree endoscopes. In this particular study, we also looked at our instruments, a 0-degree microdebrider, a RAD 60, a RAD 90. Again, you can see that trend of improvement of access to all walls of the sinus. We then looked at all the other instruments we used, the long suctions, the short suctions, the Blake sleeves, and the Hugh-Weisers. And again, you can see that the further the extent of surgery, the better the access we had to all aspects of the sinus. So really good cadaveric data to support what we're seeing clinically in our patients. This is just looking at irrigations and the extent of antrostomy. 1 represented simply removing the vertical portion of the unsnit. 2, the vertical and the horizontal. 3, extending the antrostomy posteriorly. 4, extending it inferiorly. And 5, bringing it forward as well. And we can see that it wasn't really until you created that mega antrostomy of extending it inferiorly and anteriorly that you predictively got above 80% of the sinus being heavily irrigated. So there is a benefit also, not only in disease clearance, but in the amount of heavy irrigation that you can put into the sinus with a flow bottle. So in summary, if we compare the two techniques, the canine fossa versus the extended approach, the canine fossa is probably marginally quicker, but as you get more and more comfortable with the extended approach, you can do it in under 5 minutes. There is less post-operative crusting with the canine fossa trifine. Unfortunately, because you have to cauterize that inferior turbinate, you do get a large crust that can sit there for 6 weeks. The less bone that you have exposed, the less crusting. And now I really try to fashion flaps, mucosal flaps, which are pedicled posteriorly and inferiorly. So I've got no exposed bone when I'm doing an extended maxillary antrostomy. Those patients heal a lot quicker. I think with the extended maxillary antrostomy, you don't need to buy the set that's no longer available. I also like it because I think you've got much better post-operative access. So you can surveil the sinus a lot better post-operatively. You can also access the sinus in your rooms better post-operatively. And I also think that you've got a lot less number of long-term complications. So in the final part of my talk, I'm going to speak to you about the pre-lactameral approach, which has obviously gained significant interest in the last 3 or 4 years, even though it's been around probably for a little bit longer than that. So I'd like to talk about a case example, and this was a patient that was referred to me with an inverting papilloma that had recurred 5 times. And this was a scan when the patient saw me. And here you can see the reason why this patient has recurred, because the area of origin, that osteitic portion, is located anteriorly, and if we look axially, laterally as well. So it's in the most difficult part of the sinus to access through a standard or even a mega antrostomy. And so the surgeons would go back in, they would remove as much as they could see, and then obviously the most critical portion was left untreated, and that's why the patients recurred. This is a schematic of how to do the pre-lactameral approach that we've published and is available on IFAR. Essentially, it involves making an incision on the lateral nasal wall, extending it down below the head of the inferior turbinate. So you need to come anterior to the inferior turbinate, right down onto the floor. You then use a freer or an elevator to lift the turbinate mucosa off the lateral nasal wall. And here you'll see that transition zone between the lateral nasal wall and the anterior maxillary wall. You then make your osteotomies. Now, when we initially described this technique, we would actually encompass a little bit of the anterior wall. We no longer do that. And we do that because we don't want to create the notching that you can often see with the Denker's approach. So by placing the osteotomies behind, entirely on the lateral nasal wall and not involving the anterior maxillary sinus wall at all, you're not disrupting the piriform aperture and you won't get any notching whatsoever. These are postage stamped osteotomies. You can then remove the bone very easily. And the bone will fracture around the natural dehiscences. And we know that where the lacrimal duct traverses through that lateral nasal wall is a natural dehiscence. So the bone fractures very beautifully around the lacrimal duct without causing any trauma to the duct. If you want to get extended access, you can remove the bone posterior to the lacrimal duct. And here you can see that we're doing it in this particular case. And that will allow you to move the lacrimal duct back and forth to access the maxillary sinus. And here you can see that you've got really good access to that, the entire wall of the sinus. Post-operatively, it needs one stitch. You reconstitute the inferior turbinate, the best physiological operation in terms of all of the extended approaches because you're not disrupting the inferior turbinate at all. So here's a video that that we did now 6 years ago with one of my first fellows, David Morrissey. Here you can see the patient that we spoke about previously. You can see the large antrostomy. They've taken a little bit down of the inferior part of the lateral nasal wall, but not completely. And here's the pre-operative endoscopy. So you can see large antrostomy, but they've left that disease behind. So here we infiltrate the lateral nasal wall, just anterior to the head of the inferior turbinate. And then you make an incision down on hard bone using a 15 blade. And you really want to extend it below the axilla so that you can remove the entire mucosa off that lateral nasal wall. And this is all pretty quick, and it's nice to do with suction instruments. As I said initially, we would expose that anterior maxillary wall. We don't do that anymore, and we leave that strut basically alone. Here are the osteotomies, and you can see that they're just postmark osteotomies with a 4 millimeter curette, and we remove that the bone. Once that bone has been removed, it's very easily removed. You can see the nasolacrimal duct posteriorly. And now we've got a 0-degree scope looking straight at that origin site where the site of recurrence is. So you've got a beautiful straight view. Now, to improve anterior access, you can drill down a bit of the anterior wall to give you sort of line of sight access to the tumor. And here you can see that we're addressing this tumor the way that we address all inverting papillomas, by really stripping the mucosa off the attachment, finding the bony spicules, and you can see the pepper pot appearance of that of those epithelial rest cells. And here we're now removing this tumor origin. And so we've removed all the mucosa. We can now turn our attention to the bone. That's the likely site of origin. And here we'll then have direct access. We're using a 15-degree burr, diamond burr, and we'll drill down that origin site. This patient now is 6 years post-operative and hasn't had a recurrence because we've addressed the site. So you can see all through that surgical window, we haven't had to go transeptally. We're going entirely through the ipsilateral nostril. We've got good access. And then we've reconstituted the turbinate with 2 stitches in this case, but often you can get away with 1. So it's a really physiologically nice operation. It gives you great access also to the pterygopalatine fossa, to the infratemporal fossa, without needing to go transeptally and risk a septal perforation. So I suppose my take-home points from today's talk is that think of the maxillary sinus in terms of the extent of disease. Don't simply be a technician. Consider the disease extent to allow you to determine how much surgery you do. Also, don't be frightened to do a primary extended approach. And for patients with cystic fibrosis or thick fungal disease, where you're not going to get complete disease clearance, these are the patients that are going to fail And rather than letting them fail initially, just do the megarantrostomy early and get all of the disease out. I'd always consider doing a secondary or a revision antrostomy if there's a high burden of disease. Those are the patients that you might want to try with a large antrostomy to start with, and if they fail, go to that extended approach. But the extended approach has such low morbidity, if it's done correctly, that I'm doing more and more primary extended antrostomies for now. And that's all I've got to talk about today.
That was great. Thank you very much for such an excellent talk. I think, so early on in the conference, it's really important to go over the maxillary sinus, because I always see the maxillary sinus a bit akin to a septoplasty. It can be very complicated, and the surgery to it can be complex and very tricky, but it often gets left to the most junior members of the team, and therefore doesn't always get done as well as it should do. So that was really excellent to go through all that. Now, Ashok, do we have time for a couple of questions?
Yes, please. Yeah, please go ahead.
That would be great. So one of the questions we wanted to know was, you've explained the surgery. Do you have specific techniques that you use in the post-operative period? So, for example, how often would you see the patient back? Would you be debriding the patient for any crusting? And do you use any specific rinses or topical steroids?
Yeah. So I'm a big debrider. So I see my patients between 1 and 2 weeks post-surgery. And I think you can't underestimate the importance of getting rid of as much of the crust and the clot as possible. The more you leave behind, the more bacterial colonization of it, the more you're going to get a post-operative infection. So I will, for my megarantrostomy, similarly to my drill outs, set aside between 10 to 20 minutes to get rid of all the crusting after surgery. Once I do that, I have a low threshold to put them on pulmocort irrigations. So I'll start the budesonide irrigations at 1 to 2 weeks, and I'll keep it on them until the mucosa has completely mucosalized. Now, these patients often have chronic bacterial infection. And so in these patients, if you've got a preoperative swab that's grown Staphylococcus or a preoperative swab that's grown Pseudomonas, I would have a really low threshold to start them on topical antibiotic irrigations early on in the postoperative period. There have been studies that are coming out now that are showing that if you can get your patients onto mupirocin early, they actually have less crusting because they've got less Staphylococcus within the nasal cavity. So I'll do that early. It's really, really important, and this is just emerging now, that the irrigation solution that you put your topical antibiotics in is also of critical importance. So simple saline and the non-buffered solutions and the solutions that have got a neutral pH aren't great for your topical antibiotics. So there are some manufacturers in Australia who now use a slightly acidic pH, and for the mupirocin, it's a lot more stable and works a lot more effectively than in a neutral pH.
That's very useful. And
sorry, Louise, then 6 weeks. 6 weeks will be my second post-op.
After that, after the 1 to 2 weeks. And just out of interest, the mupirocin, does that come for you in an ointment form that you then mix, or do you have that in another form?
So I've got a couple of compounding pharmacists. One makes a powdered form. One makes a gel form. I think, it's really hard. Obviously, it's quite expensive too. So what I would advocate to anyone anywhere in the world is find a compounding pharmacist. The concentration that you want is 0.05%. That's the ultimate concentration. Get your compounding pharmacist. They'll be pretty eager to make it for you. And then if you send them enough work, the prices come down pretty quickly.
Okay. And just lastly, Alkis, if that's all right, somebody had asked, shouldn't we be using the new immunologicals when dealing with these patients with eosinophilic disease and high inflammatory load?
So very good question. And I think there's definitely a role for biologics. So not part of my talk, but I do histology on all of my patients. And so if they're eosinophilic, I'll try the Pulmicort or these oral steroids initially in these patients, because we know that eosinophils respond really well to corticosteroid therapy. If they're lymphoplasmitic or lymphocytic infiltrates, I will put these patients on macrolides for 3 months. And in those patients, they do much better. They don't respond to the steroids. Biologics definitely have a role. I think the biggest issue is cost, and the fact that obviously you can't be giving everyone biologics because the governments wouldn't support it or afford it. But I would certainly say that there is a role for them. The interesting thing, and I wouldn't mind hearing Sal and others on the panel, when you have a patient with pansinusitis, essentially the places they recur, if you've done a megaantrostomy, is never the maxillary sinus. It's the frontal sinus, it's the skull base high up. So the dependent portions actually do really well with this extensive procedure. And I think it's the fact that the Pulmicort or the budesonide sits in the sinuses after they wash, and it bathes the sinuses. So for the maxillary sinus, I don't think the biologics are as important. They're more important for the recalcitrant frontal ethmoid sinusitis patients. Sal, do you have an opinion about that? Do you see that where the maxillaries look good despite the rest of the sinuses looking pretty bad?
Yeah, in fact, that's often the case, Alki. In fact, the case just this week that I did on Thursday is exactly that. Maxillary sinuses look great, but we don't obviously get Pulmicort. We have sort of equivalent, but not as good, budesonide, and it does pool in the maxillary sinus, and often the maxillary sinus looks great, but the narrower you go and the higher up you go, A, because you're not getting the ventilation, but B, it's not pooling in the sinus.
Yeah.
That's great.
The impact time is much less. So, yeah.
Well, that's great. Thank you very much for that. That was an excellent talk. Very much appreciated.
Thank you.